I'm seeing more and more residents give furosemide for postpartum hypertension. But when I ask them what the evidence behind this practice is, who the right patients are, and how to actually use it, I get blank stares. Different timing, different doses, they tell me the decision depends on who is the staff covering the floor that day. That inconsistency should make you pause. To my surprise, I could not find any published guidelines from national organizations, and that made me wonder if we even have any evidence behind the practice. So I took a deep dive into the research using AI and looked at the randomized trials published on the topic in the last 25 years. In the next few minutes, I'll give you a practical, actionable summary of what I found. Question number 1. Is there any evidence backing up the use of furosemide for postpartum hypertension? I found 8 randomized trials, going all the way back to 2002. The one with the most citations was published in the Green Journal in 2005, and it showed that the furosemide accelerated blood pressure recovery and reduced antihypertensive medication needs. The rest of the trials showed an overall similar pattern, but they used different dosing and routes. But here's the catch. The effect is modest, and it does not improve all the outcomes associated with this condition. Hospital readmissions, no benefit. Major complications, no reduction. So yes, there is evidence, real, peer-reviewed evidence, but it doesn't mean it improves all the clinical outcomes we care about or that we should use it in everybody. We can recognize that benefit exists, but only for the right group of patients, which brings us to the next question. Who are the patients that benefit from this intervention? Is it every patient with postpartum high blood pressure? Not exactly. The 2 largest trials showed that patients with preeclampsia with severe features are the ones that benefit the most, once magnesium sulfate is discontinued. For other hypertensive disorders, the effect is limited, negligible, or even harmful. For example, it is not recommended for patients with superimposed preeclampsia. A 2023 study suggests that it could actually prolong hospital stay in this population. That's why giving it across the board doesn't make sense. So make sure you use this medication in the right population. And that leaves us with one more question. Once we've chosen the right patient, how do you actually use it? What dose should you use? How long should you continue it? And what should you watch for? Most of the largest trials lined up here. They used oral furosemide. Typical dose, 20 to 40 milligrams once daily. Course length, 3 to 5 days postpartum. Timing, as soon as magnesium sulfate has been discontinued and diuresis has resumed. What about potassium supplementation? Only 3 out of 8 studies used potassium supplementation, and in the other 5 that didn't, no cases of hypokalemia were reported. My take on this? Potassium supplementation is not required in all patients. It depends on baseline labs. And do not forget the red flags. Avoid furosemide in women with renal insufficiency. Avoid it if they're already hypovolemic. Avoid it if potassium is low to begin with. Remember, if you prescribe it, stick with a short course, monitor carefully, and know when to hold back. Quick pause before the bonus tip. Are you a resident trying to keep up with evidence-based care, smarter teaching strategies, and the latest in AI? Pathways OBGYN gives you bite-sized education made for the busy resident. Clear, practical, always up to date. Your shortcut to staying sharp without wasting time. Hit subscribe now so you don't miss out. Here's the bonus. Furosemide does not work in isolation. I've seen residents use it prior to starting an antihypertensive. The most important randomized trials looked at it in combination with standard antihypertensives, especially nifedipine. Think of furosemide as an add-on, not a standalone drug or a form of prophylaxis. So let's wrap this up. There is evidence. Multiple trials show furosemide helps, but it only helps in women with preeclampsia with severe features and only improves 2 very specific outcomes. 1, it accelerates blood pressure recovery. 2, it decreases the antihypertensive needs. It does not decrease hospital stay, readmission, or other major complications. Start as soon as magnesium is off and diuresis has resumed. Order 20 to 40 milligrams daily for 3 to 5 days, and only supplement with potassium if there's baseline hypokalemia. Share this video and subscribe to Pathways OBGYN for evidence-based updates, teaching hacks, and smarter AI strategies.